Good evening, ladies and gentlemen. Welcoming all to another edition of VGP Online Academic Series. And today we have a very different topic and an extremely promising young speaker to deliver the same. Alzheimer's disease is one of the areas in which maximum research is being conducted all over the globe. Treatment modalities to arrest the progression or to reverse dementia is being researched since long. And varied degree of progress has been made in that direction also. So if we can diagnose Alzheimer's disease using certain biological markers, that is going to be the first step in the progress towards absolute cure of the illness. Because if we can identify the illness early using biomarkers, we can start the treatment and interventions and lifestyle modifications with meticulous precision at the earliest so that we can arrest the progression or even probably reverse it in future. To talk about this topic, we have an extremely promising young psychiatrist, Dr. Mithun P Devasia. He is specialist doctor in older adult psychiatry in the CNTW NHS Foundation Trust, United Kingdom. And I'm proud to say that Dr. Mithun Devasia was my student, and with great pride introducing Dr. Mithun Devasia to this August audience. And to start the proceedings for the session, over to our extremely vibrant moderator, Dr. Neenu SS. Over to you.
Thank you so much, sir. Good evening again. Uh, like Sir said, today's topic is biomarkers in diagnosing Alzheimer's disease from research to clinical practice. It is common knowledge that approximately 60 to 70% of the global dementia load is contributed by Alzheimer's disease. And yes, but whatever the current diagnostic tools that we have are either invasive, it is invasive and expensive, and therefore it is of utmost importance that we develop biomarkers using biofluids like blood, urine, saliva, etc., which are more reasonable, less invasive, and also it can enable us to objectively evaluate Alzheimer's disease. So to speak about this topic, we have with us our alumnus, Dr. Mithun Devasia. Like Sir said, Sir has already introduced, he is a specialty doctor in older adult psychiatry in CNTW NHS Foundation Trust, United Kingdom. We are extremely glad to introduce him to you, and glad to have you here, Mithun, and over to you.
Thank you, Nino, and thank you, Arun sir. I'm very happy for the organizers to give me an opportunity to speak on the topic. So, like both Arun sir and Nino explained, my topic for today is biomarkers in diagnosing Alzheimer's disease. So, I've named it from research to clinical practice. So, we'll be talking about something that's in place now and where is research heading this towards. And obviously, we'll also speak about some of the guidelines who are taking this into consideration. So obviously, when I was given an opportunity to present, this topic came to my head first because I've been always keen on early diagnosis of dementias, particularly Alzheimer's dementia. So I'm fortunate to currently being involved in a study which focuses on very late onset psychosis, which we test dementia biomarkers and then see whether they kind of develop dementia in the long term. And also I'm part of a team developing a learning module for the Royal College on Alzheimer's disease and biomarkers. I'd like to start this presentation by acknowledging Dr. Barber, who is consultant neurologist psychiatrist of the trust and honorary clinical senior lecturer who has helped me. So let's start with the relevance. So as we know, still Alzheimer's dementia is a clinical diagnosis. It's largely a clinical diagnosis. What is the issue with that? Like I said, the burden of dementias is on a higher side, and the problem with that being there is a mismatch between the pathological and the clinical form of diagnosis. So what we diagnose clinically is not in line with the pathological changes in the brain. So there is a difficulty in that regard. And there's also a need of an early diagnosis, hopefully, and to plan maybe one's life ahead accordingly. So a diagnosis helps in a lot of ways. When someone is having capacity to take life decisions, a diagnosis might be useful to decide on their, for example, their will, or for example, how they want to plan their life forward. So that is again an important in terms of an early diagnosis. And the biggest positives with regards to what happened is uh, now we are in the era of disease modifying agents, and many of you might be aware that FDA has approved two molecules which are anti-amyloid therapies, namely lecanemab and donanemab,
namely
who
lecanemab and donanemab, who
uh, which sorry, so which would be which is FDA approved, although there's still post-mark studies taking place about the long-term use efficacy. The cost of these medications are also in question. So it's still, we are in this process of research and era of disease modifying agents. So again, a diagnosis through a biomarker or a molecular route would aid us uh, in terms of making this treatment accessible to the relevant population. So when I said about the disparity between the neuropathological and the clinical diagnosis, I would like to mention the study that was performed across by the National Institute of Aging from 2005 to 2010, where they looked at what was the diagnosis of AD clinically versus what was seen in the neuropathological domain. So if you see on the left, they used very specific neuropathological diagnosis of AD. One is the SARAD NP, which is either moderate to frequent or frequent. And then it's the backstaging. So both of these are the pathological diagnosis, where one focuses on the amyloid plaques and the backstaging focuses on the neurofibrillary tangles. So depending on how much part of the brain is involved, uh, that is how you stage this. And so interestingly, if you note, the sensitivity and specificity of clinically probably AD versus definite AD, which was confirmed by obviously postmortem examination, is less. So that's why we need to be more accurate in our diagnosis clinically, and we need to look at the measures for that. So most most importantly, when it comes to diagnosis, you'd have nothing kind of makes a difference unless you have a full detailed history, focused physical examination and a mental state examination, including cognitive examination, considering all the differential diagnosis, looking at the formulation in a diagnostic way. So that's still the first line. Why should we develop a clinical criteria? So obviously, uh, like I mentioned before, it's important that we determine the clinical stage of the illness. We characterize what is the likely cause of this dementia based on diagnostic criteria. Uh, and if you look at the main diagnostic criteria, there's always been certain consensus criteria. And recently, the DSM-5 introducing the term called major neurocognitive disorder and ICD-11, which is closely in line with the DSM-5 criteria. It remains the most clinical stay of diagnosis. Again, neuropathological criteria is different. Touched a bit on that previously. Obviously, you have the uh, neurofibrillary tangle score, the neurotic plaque score, which is the SARAD score, and you also have the TAL criteria, which is based on the amyloid plaques and how much areas of it is in the brain. So I'm not going into detail of the clinical criteria, but just to make everyone brush up the knowledge. Obviously, this is on the left, it's the ICD-11 criteria, which diagnoses dementia when there's a marked impairment in two or more cognitive domains related to the expected levels of individuals' premorbid functioning. And on the right, it's the Alzheimer's probable and possible diagnosis according to DSM-5. So for again, as per DSM-5, you need one or more of the domains to be affected, cognitive domains to be affected. And for probable Alzheimer's disease, you'd have to either have evidence of causative cause through genetic testing or a focused his family history, or you'll have to uh, you'll have to get detailed cognitive testing and looking at other ruling out other etiologies through proper methods. And possible Alzheimer's is diagnosed if the above criteria are not met. So what is biomarkers doing different? So Alzheimer's pathology can be detected in life. So it's like the fingerprint of Alzheimer's disease can be seen in earlier parts of the life. And with the help of increasing accuracy by techniques like ultrasensitive biofluid techniques or ligands to use in PET scan, has made a difference to detect this Alzheimer's pathology early in life. And understanding the intersection of molecular biomarkers, like there is amyloid, which is one. There's also changes in the tau side of things. Again, the changes happening in the brain is different to the changes happening in the CSF. Also, the changes happening in the blood as well. There's also genetics at play with all the relevant risk factors. So how much can be put in as a criteria? Or is AD a biological construct, or is Alzheimer's disease as a clinical biological construct? So there's been like two schools of thought uh, getting on that. We'll come to that in detail. So there is a concept of AD continuum. So means that Alzheimer's pathology exists in someone's life before the dementia stages. So it's the dementia stages where we are able to clinically diagnose someone with dementia. But there is the mild cognitive impairment stage before that. And even before that, there is the cognitively non-impaired stage. But still, Alzheimer's disease can exist in someone, maybe in the brain. So this is when the biomarkers can play a role. So this is where questions are asked about prodromal stage versus proper Alzheimer's dementia, or is it like the changes that can happen with aging? That is questions asked with regards to the AD continuum. Then another thing is the clinical heterogeneity of AD. There are atypical Alzheimer's presentation, namely the posterior cortical atrophy, which can present with visuospatial symptoms. This is the most commonly the amnestic form of AD. There's also a frontal variant of AD, which can mimic its presentation with the frontotemporal dementia, but which is also called the atypical form of AD as well. And again, while developing a diagnostic criteria based on like biomarkers, another thing to consider is it's very complex how AD is not understood just by amyloid or tau or other neuroinflammation. And a lot of patients with Alzheimer's disease have also coexisting conditions, like they may be positive for Lewy body disease, or they may have coexisting vascular dementia, which makes the development of uh, probable diagnostic criteria based on uh, biomolecules a bit different. So, like I mentioned, there were two schools of thoughts which came up in terms of how we can define AD as a biological construct or as a clinical biological concept. So one is the National Institute of Aging Alzheimer's criteria, and the next one is the International Working Group criteria. So the major differences being National Institute of Aging criteria is purely considering AD Alzheimer's as a biological construct, So it is presence of the disease means the pathology is existing in your body. And even if the patient doesn't have any symptoms, but has the biomarker positive, it is AD according to the criteria or according to the school of thought. But it is not done. It can be diagnosed as in asymptomatic individuals, like it's written there. But it should not be done for clinical purposes at this time because there's no treatments or there's no there's no evidence that a diagnosis of Alzheimer's disease in such an individual uh, can lead to a meaningful change at this point of time. That's why the NIA criteria mentions that. Well, if you come to the international working group, so they kind of define as at risk if there's no symptoms, but you have a positive biomarker. So it is a clinical biological criteria. It looks into the clinical presentation and also takes into what is the pathological process. So there's a clinical positivity and the pathological process. So if you don't have any clinical features of dementia, you're just at risk of developing it. And again, they clearly mention biomarkers should not be used for diagnosing in asymptomatic individuals. So we'll come to that in detail. So which were the biomarkers mentioned by National Institute of Aging? We have, so basically there are a few classification of biomarkers, but we'll just keep it short in terms of amyloid biomarkers and the biomarkers of brain injury. This is as per the National Institute of Aging. So amyloid can be detected, one by neuroimaging, one by CSF, now by blood as well, but we'll speak about the blood later. So beta 42 reduction in CSF or increased positivity or radiotracer detention in an amyloid PET scan is an amyloid biomarker. The tau biomarkers are more injury related and are non-specific to Alzheimer's pathology compared to amyloid. There's an increase in total tau and an increase in phosphorylated tau in the CSF. If you do a FDG PET scan, there is a reduction of temporal and parietal cortex metabolism. If you do an MRI, specifically looking at the lobes, so there is atrophy in the temporal lobe and the medial parietal cortex. International Working Group criteria does also have as biomarkers similar to what I mentioned, FDG PET, MRI, amyloid A beta 42, and the tau in CSF. Additionally, they also mention the genetic testing. So like I mentioned, the biomarkers can detect the amyloid pathology, they can detect the tau pathology, and they can also detect other markers of neurodegeneration. So other markers could be the total tau. So while the phosphorylated tau is more specific to the tau pathology, the total tau is more linked with neurodegeneration or injury. Neurofilament is another biomarker, and glial fibrillary acidic protein is also a biomarker for neurodegeneration. So I'd like to introduce the revised criteria, which was developed by the Alzheimer's Association Working Group in 2004, which actually categorizes, give a construct to Alzheimer's disease and categorizes the biomarkers into core biomarkers, non-specific biomarkers, and non-AD co-pathology biomarkers. So the biggest statement that the AAW made is Alzheimer's disease is a biological continuum in living individuals. And if you have a positivity of a core 1 biomarker, you can consider diagnosing Alzheimer's disease in someone. So which are the core biomarkers? The core biomarkers are one which is more relevant to the Alzheimer's pathology or the neuropathologic change. Namely, it is the amyloid biomarkers and the tau biomarkers. So they are the core 1 biomarkers. So it's the amyloid pathology either through the CSF or through amyloid PET testing, and tau to the tau PET testing, or through the phosphorylated tau in CSF. The non-specific biomarkers are important in Alzheimer's pathogenesis, but they are also involved in other brain diseases. Hence, they are not the core biomarkers to diagnose Alzheimer's disease, but they are important. They might be important in staging or prognosis, or to look at a biological treatment effect in the future. So these are characterized as N and I. So N is the one that stands with neuronal injury, dysfunction, degeneration of the neuropil. So it's a neurofilament. And I is the inflammation through the astrocyte activation. Glial fibrillary acidic protein is the biomarker connected to it. Then there's also the V and S biomarkers, which is the non-AD co-pathologies. So it is useful to identify any existing co-pathology along with Alzheimer's disease. And V stands for the vascular brain injury, while S stands for the alpha-synuclein, which can be present in other neurodegenerative disorders like Lewy body disease, and vascular brain injury can be present in vascular dementia. So the evidence for that would be the infarction through CT, MRI, etc. So what there's been like a big interest recently is the core biomarkers used for diagnosis also include the blood biomarkers. Specifically, this molecule has now been like making a lot of noise in research. That is the p-tau 217. So phosphorylated tau 217 and lots of ratios associated with it has been a game changer in terms of diagnosis. There's also other hybrid ratios, including other phosphorylated tau molecules, which is a phosphorylated tau 181, the total tau by A beta 42 ratio. In the CSF, A beta 42 by 40 ratio would be the biggest kind of biomarker that we need to look at in terms of diagnosis. Because the A beta 42 deposits in the brain, when you check the CSF, there is a lower level of the A beta 42 compared to the normal level. So if you take a ratio of A beta 42 by 40, it will be low, and that is diagnostically suggestive of a positive biomarker. We'll come to the plasma tau 217 in detail. So like I said before, with regards to the core biomarkers, they were again subclassified into early changing core biomarkers and later changing core biomarkers. So the one which can be detected like early in life, one would be the A beta 42, or in terms of tau-padi, there are other non-phosphorylated forms, or MTBR tau 243. The later changing core biomarkers provides more around prognostic information, an increase in confidence of that AD is contributing to symptoms. So I'll give a clinical scenario which we came across where we had used biomarkers effectively. So this was a 65-year-old female with 6 to 12-month history of mild memory difficulties initially. But then while this was being happening, she had a florid psychotic episode, recurring active treatment with antipsychotics. But even after the recovery, there was ongoing deterioration of memory, and the latest ACE3 testing revealed a score of 67. So it's not a clear picture in terms of what could be causing her neurodegeneration and what could be the clinical diagnosis. Obviously, we'll have to do an assessment of her functioning, current status, detailed mental state, history. But in terms of what we know about the biomarkers and what are the tests that are available to us, probably thinking from a UK setting, to increase the diagnostic confidence. So obviously, the first step would be neuroimaging, and an MRI brain would be a good first step to look at whether you'll get any supportive evidence to diagnose any subtype of dementias. So we need to take an MRI brain, a dementia protocol MRI brain, which will have to tell the radiologist to report focusing on any lobar degeneration, lobar atrophy, any atrophy specifically to the medial temporal lobe. So you can ask to report an MTA score if possible. You can also ask about reporting it in a CODEM score, which looks at the posterior cortical atrophy. FASECA score is important in terms of vascular pathology. So that is what we can ask for. So fortunately, in this case, there was no clear evidence. There was no evidence of a medial temporal lobe atrophy or any atypical Alzheimer's dementia presentation, which can be inferred from the MRI. So the next step, what we had to do was to do like a PET scan. So I mentioned in the presentation an amyloid PET is like a very gold standard test to detect Alzheimer's pathology, but it's only used in research settings and the cost of it is very high. So we can do an FDG PET scan to look at the cerebral metabolism. And there might be some patterns which helps us to differentiate between types of dementias. For example, if you're suspecting a Lewy body dementia, in a FDG PET scan, you can get reduced blood flow. So you can get metabolic changes in the occipital lobe, for example. So there was no kind of clear picture from an FDG PET scan as well, which made us in a situation whether what to do next. And obviously, because there was no core features that it was likely to be a Lewy body dementia, in that case, a dopamine transporter scan or a DAT scan would be an option to look at Lewy body, whether it's Lewy body dementia. But the team decided to actually do a CSF study and see whether is there an Alzheimer's pathology contributing to it. So it was done with the help of neurology colleagues, and the result was we were able to identify an early Alzheimer's disease. A beta 42/40 ratio was less, the total tau was high, and the phosphorylated tau was high in CSF. So this is a logical pattern that we might use in terms of the available biomarkers to increase diagnostic confidence in such a case. Now coming to the Alzheimer's Association clinical practice guideline on the use of blood biomarker tests. So there's two recommendations and one good practice statements for the use of blood-based biomarkers in diagnostic workup of patients, again, with someone who has an objective cognitive impairment and seen in a specialist care. So these are not tests that's currently designed to be done in a primary care setting. It's done in secondary care and the patient has objective cognitive impairment. The first recommendation is that in patients with objective cognitive impairment presenting in specialized memory care, a high sensitivity blood biomarker test that is more than 90% sensitivity can be used as a triaging test for diagnostic workup. The second recommendation is the same set of patients. You can use a high sensitivity, high specificity blood-based biomarker test as a confirmatory test as well in diagnosing Alzheimer's disease. So this is important in terms of what is a good practice statement that the panel recommended. So a blood-based biomarkers test should not be obtained before comprehensive clinical evaluation by a healthcare professional. The test results should always be interpreted in a clinical context. Panel urges clinicians to consider, again, the case-by-case basis, whether to decide someone need to go for a positive blood-based biomarker test. So while the blood-based biomarker tests are going to be a game changer, there needs to be a careful discussion about which patients needs to be used and who will it be suitable. So this is what the panel also recommends with the good practice statement. If you come to the NICE guidelines in the UK, what does it say in terms of diagnosing dementias? What are the biomarkers which we can currently use and approved by NICE to diagnose dementia? So it recommends structural imaging. And if there is no evidence of a particular dementia subtype from the structural imaging, you are allowed, it is recommended to use further tests to diagnose dementia subtype if knowing about the dementia subtype would change management. So for example, if we are really confused with the presentation of someone with a frontotemporal dementia and a frontal variant of Alzheimer's disease, we know that the current medications, the acetylcholinesterase inhibitors, can worsen presentation in frontotemporal dementia. And it's not recommended in someone with frontotemporal dementia, but it is a treatment of choice to worsen the progression in Alzheimer's type frontal dementia. So in this scenario, knowing about the dementia subtype would change your management. So in that case, NICE recommends you to use FDG PET scan, which looks at the brain metabolism for diagnosing Alzheimer's disease, or a perfusion SPECT, which looks at the blood flow. It also recommends you can use the CSF tau and amyloid markers. So this is where NICE stands in terms of biomarkers. So you see the blood-based biomarkers are not there in any of the guidelines by NICE. So this is a very useful kind of picture to see how early can we detect the biomarkers and when someone is presenting clinically versus how he's like asymptomatic, but can be still biomarker positive. So if you look at the biomarker abnormality that comes first, it's the A beta in the CSF can be detected the earliest, followed by if you do an amyloid PET scan. It's not a FDG PET scan, it's an amyloid PET scan. In the amyloid PET brain scan, it will be positive. CSF tau comes at a later stage, followed by MRI will be able to see the classical medial temporal lobe atrophy, followed by an FDG PET scan. And you see the mild cognitive impairment or the cognitive impairment in terms of dementia happens much later. So we're able to, predict the Alzheimer's pathology in someone's body through test right before when someone is clinically having dementia. So just a few points about CSF testing. So CSF is an invasive procedure. Obviously, you have to do a lumbar puncture. So what is recommended is collecting a 500 microliter of CSF in 2 separate tubes of polypropylene. Not use glass because it can affect the values because there is adsorption to the tube also. The suggested form is polypropylene. There needs to be storage, and storage is a tricky bit. And in the UK, not considering like private sector, most of the testing is done in the UCL University College lab in London. So the samples might need to be transported there. So what is the kind of thing that we need to look at in the CSF? I mentioned this before. There's a low A beta 42/40 ratio. Again, this values might differ based on the center of testing. So we'll have to use the values relevant to the center where you test. And it has an 85% sensitivity and 90% sensitive specificity in detecting the beta amyloid deposition as measured by amyloid PET. So you're comparing amyloid PET to A beta 42/40 ratio, and it has a good approximation. Elevated levels of beta 181 reflects the CNS neurofibrillary tangle pathology. Other measures like total tau, the neurofilament, are non-specific markers of neuronal injury, damage, or inflammation. So when you order a CSF panel, you do total tau, you do elevated tau, you do neurofilament at times. You also specifically do the A beta 42/40 ratio. So I'll come to the top, the kind of the blood biomarkers. I did mention about the panel recommendations, but why is this test kind of making the headlines in the world of dementia research? So this is plasma p-tau 217. It's emerged as a single most promising test, blood-based biomarker for diagnosing Alzheimer's disease. Why is it unique is it is a marker of brain amyloid as well as early tau pathology. So if you discuss previous markers, like for example, the A beta 42/40 ratio, it was more specific to the amyloid, and you are kind of not looking at the tau pathology, but p-tau 217 has found through studies and correlations that it is a marker of amyloid deposition in the brain as well as the tau pathology in the brain. So it's a unique in that as again the biggest positive of p-tau 217 test is it can be performed in peripheral centers, in memory clinics, and even places with a limited resource setting. So you don't need to do an invasive procedure. You just need to collect your blood. The collection you mentioned, you need 4 to 8 ml of blood in plasma EDTA. Short-term storage can be done at like 4 degrees Celsius. Long-term, if you're doing long-term storage for testing, it needs a very specialized setting. So currently, based on the appropriate use criteria and all the consensus, it is only to be used as a diagnostic adjunct, meaning if someone is asymptomatic, you don't offer a p-tau 217. Again, whether it should be used as a screening test in primary care, there are a lot of debates on the topic, but we need a careful history, a cognitive examination, and a very clinical objectivity before we kind of add this p-tau 217 to the picture to consider. And you have to use reference values in relation to the test panel specification. So like if you're testing in a specific lab, it would have the test panel values and you would have to use that. Well, p-tau 217 is affected by other factors as well. And there needs to be more research and studies into the reference values when particularly someone has a poor kidney function, because poor renal function can increase the levels of p-tau 217. So we need like separate reference values, which are still under going to be looked. And someone who is like obese can have low levels of p-tau 217. So again, these are factors that need to be considered for careful interpretation. And it's important to proceed with 2-point cutoff rather than a single observation for p-tau 217. I'll explain that in the next slide. So 2-point cutoff provides like more stronger accuracy in terms of positive predictive value and negative predictive value than a single cutoff, making more real world reliable application for early detection in real world settings. So for example, in this panel, for example, the cutoff is 0.229 to 0.516 picogram per milliliter. More than 0.516, someone's p-tau 217 came out to be more than 0.516. There is a high probability of amyloid positivity. If it's less than 0.229, there's a high probability that someone is amyloid negative. If someone is between the 0.229 and 0.516, it's an intermediate result, and the current recommendation is to consider an amyloid PET or a CSF assay in such individuals. It is not a straightforward interpretation based on the results because, like I said, amyloid pathology can coexist in Lewy body disease, for example, or other forms of dementias. So you might end up people getting positive, or amyloid deposition increases with age. So p-tau 217 deposits increase with age as well. So we need more robust research into developing standards in terms of what are the exact values for different populations or different conditions. So what are the concerns? So well, there have been lots of concerns and questions raised about the blood-based biomarkers testing. Is it a good screening option, or there's a concern that the wider availability of the test in the future may lead to issues. So more than getting the test available for all, it's choosing who needs the test, and that's when you need to carefully interpret the result as well. So there might be a scenario in the future where the test can become widely available, maybe even in the primary care setting, and people might end up getting tested without any features of dementia or clinical features of dementia at all, and they may be coming to the memory clinic settings or specialist settings saying that, look, I've got a positive test, what should I do? Which would always, this is a different way of looking at it in terms of someone could be really anxious whether he might get dementia, although currently he doesn't have any clinical features of dementia. So there's lots of things to be considered before it's widely enrolled. And like I said, it can also be the blood-based biomarkers can share positivity in vascular dementias or other neurodegenerative disorders like Lewy body disease. So currently, anti-amyloid therapy, if you're considering someone for anti-amyloid therapy, it requires careful confirmation with amyloid PET scan or CSF amyloid positivity, and need a careful MRI review because of the problems or the risk of hemorrhages or amyloid-related infusion reactions and microhemorrhages associated with a lot of molecules. So currently, the blood-based biomarker testing doesn't get you anywhere near having an anti-amyloid therapy. So the biggest question, like I've raised, is should the test be restricted to a specialist memory clinic and in research settings? So that might be currently what we're thinking forward, but it's open to discussions. I just want to mention, so in the UK, the UCL has actually initiated a large clinical trial based on p-tau217 in collaboration with the Alzheimer's UK and Alzheimer's Society. The trial is planning to be done in the next few years, aiming to recruit like 1,100 participants referred to memory services across 20 NHS centers. And they're able to see whether p-tau217 testing using p-tau217 can enhance speed, accuracy, or accessibility of Alzheimer's diagnosis in NHS memory clinics. So this study would give us a real world picture and more robust idea into how much of a blood-based biomarker test can be weighted to our current standard testing in terms of A-beta for Alzheimer's amyloid PET or A-beta 42 in the CSF. So that's it for my presentation. Thank you everyone for listening.
Thank you so much, Dr. Mithun, for that enlightening session. We shall now take doubts and comments. Kindly put it in the chat box or unmute and ask. While we wait, Mithun, can you speak to us a bit about your study that you're a part of?
So this study, we are looking at very late onset psychosis who are presenting first episode, who doesn't have current cognitive symptoms. But so we are taking the psychosis by itself. We're doing neurodegenerative markers when we first see them. Then we're planning to follow them up for a year and kind of do the biomarkers again. So we're doing the blood biomarkers, the p-tau217 is a part of the study in the baseline. We're going to do MRI and also DAT scans for those people. We'll do all the clinical cognitive assessments as possible, along with measures for psychosis and mood and rating scales. We'll follow them for a year and kind of see how many will clinically develop dementia. So it's based on the theory that late onset psychosis is a driver of neurodegeneration, and it will be like a marker of dementia.
So you're taking pre-symptomatic patients or psychotic patients?
So patients who have psychosis, so it can be like depressive psychosis or just psychosis, but they shouldn't have dementia, pre-existing dementia or any other neurodegenerative condition.
Okay. So on a routine basis, do you do all these biomarkers or only it is a clinical diagnosis purely?
No, so on a routine basis, like if we need to follow the NICE guidelines in the UK, and it recommends only if after structural imaging, if you feel that knowing the dementia subtype can lead to a change in diagnosis, you can do it. Obviously, in that case, we try to do the FTG PET scan, which is more accessible. And even if that is not like conclusive of a dementia subtype, that's when we need to consider CSF, which needs longer conversations with the patient, the family. Again, it's an invasive procedure. It's not done in like a psychiatric setting, so I have to have the neurologist on board. So there's lots of consideration. An amyloid PET is really expensive and it's not accessible. So the test that we do in our settings is the CSF at the end if we don't get any other information from other tests. We also routinely do a DAT scan, which is when we consider there is a Lewy body disease in the diagnosis, and we are worried that there is a Lewy body pathology. Then a DAT scan is more accessible and it's done in a lot of centers.
Okay, how much would a
So,
p-tau 217 cost?
so I'm sorry, I don't know about the commercial availability because it's not commercially available. It's only used in research settings, and it's not clinically approved in the UK. In terms of diagnosing someone, it's not approved. So we need like the trial I mentioned, we need evidence in wider population before kind of rolled out. But early kind of reports or reviews are promising for p-tau 217 to replace the current CSF testing. Yeah.
Okay. Okay, so I think we have Arun Mohan who said, excellent talk. Are these tests available as direct to consumer basis?
No, as far as aware, it's not. It's only, at least in the UK. It might be available more in the in US, but it's not available. That's the worry as well. Once it's widely available, like kind of think of a scenario in the future where someone gets a positive test and comes to you saying that I'm worried I might have dementia. So these are all circumstances which we might need to think and interpret. Yeah.
I think Intu ma'am has raised her hand.
Thank you, Dr. Mithun. That was an excellent talk.
Thank you, madam.
Considering the in India, I think the people are planning to launch lecanemab this year. So in that context, people are all excited about all these tests, biomarkers. But blood biomarkers, are they considered as inclusion criteria for choosing patients, for recruiting patients for this lecanemab therapy?
Ma'am, I think currently blood biomarkers alone is not enough because one of the measuring factor is how much amyloid is changed in the brain following therapy. So ideally they want an amyloid PET scan before initiating therapy. So I don't think blood biomarkers can be used at present. We need more evidence whether they can be equated in the future, but currently, to my understanding, no.
So a workshop that I attended a few months back, there was one company. It was actually a Kerala-based company. They were saying that these blood biomarkers are being made available in some private hospitals in India. And the cost, as Nino was asking, they were providing it at 5,000 rupees for both the tests, A beta 4240 and P 217. So, but that rate we might not get it done from the hospitals, from or the labs, private labs. But considering the total expense of this disease modifying drugs, even for research purpose, how much we'll be able to, a country like ours will be able to utilize that? That is a major question. Your comments on that?
Yeah, ma'am, that's a very important point as well, because there's still a lot of difficulties with the disease modifying agents, because obviously people are still skeptical about when the accelerated FDA approval when it's received, and how much is it just the amyloid pathology treating the Alzheimer's, for example. So there's a lot of concerns about it, and probably the risk of adverse events as well, in terms of infusion reactions and microhemorrhages. So I think it's going to be a very huge cost to at least set up a setting where you can safely give the the anti-amyloid therapy in terms of pre-assessment, selecting the patients, requiring the scans, and even following them with routine MRIs as well. It's mandatory. You need to follow them with MRIs, and then again doing scans post the test. So it's going to be hugely expensive, and whether the cost versus benefit ratio is appropriate will be another debate.
Thank you.
Thank you.
We have two more questions. Dr. LB has asked, which investigation is preferred gold standard for Lewy body dementia?
So for Lewy body dementia, I think the current recommendation is a DAT scan, if it's possible, to get a dopamine transporter scan, which is a special SPECT scan. So it is like it measures the blood flow in the brain, but looks at more the dopamine transporter. So you'll be able to look at basal ganglia. So that scan is reported both quantitatively and qualitatively. So quantitatively, you measure the size of the basal ganglia to look at the putamen size. You look at the putamen size, and for quantitatively, you look at how much of the neurons are lost, the dopamine transporter is lost in the basal ganglia and other parts of the brain. So that scan is reported positive when both quantitatively and qualitatively there's been changes. So that is the most easiest and accessible and gold standard test. But some people might not show positivity in that scan, but still can have Lewy body pathology. There's also false positives with that scan. In that case, there is a recommendation to do the cardiac MIBG scintigraphy, which is like another molecular test. Again, I've not seen it done, because in our setting, we kind of ended with the DAT scan, but it is also a recommendation to do it. You can also do like a PET scan, but again, it's not specific as a DAT scan, because Lewy body pathology, it's the dopaminergic neuron. So anything getting the dopamine transporter measured would be the best test. Yeah, so that's my answer.
Okay. Dr. Priya Manjunath has asked, what's the current practice in UK around lecanemab and donanemab prescription? Have you seen anyone on lecanemab or donanemab? If yes, what's your experience of it?
So the current discussion in the UK here, in UK, is lecanemab and donanemab. There is like private companies who are pharma companies who are like interested in kind of enrolling it. So before you need to enroll in a NHS or a public sector, you need approval from NICE. So there was a huge kind of discussion last year about what is approval NICE had to give for it. And finally, NICE decided against approving lecanemab and donanemab in the UK for public sector. I mean, in the NHS, it's not approved by NICE. the companies have submitted an appeal, so there will be a review of the decision. But the whole thing they're saying is the price is not kind of justified to enroll it based on current evidence or thing. But it's gonna get reviewed. And again, theoretically, it's possible to get it in a private setting in the UK. I don't know anywhere if it's available or not, but it's still getting the Medicines Health Regulatory Authority approvals and things to use it. But currently, because the NICE is giving like a strong statement against it for now, that is where things lie. So they might review the decision. And the Alzheimer's, like lots of organizations and charities are also in the case with NICE to review the decision. I've not seen anyone with lecanemab, donanemab, so no experience on that. Sorry.
Okay, thank you, doctor. Arun has one more doubt. Is insurance covering the expenses of PET scan in UK?
So because in most of our patients, and I work in an NHS setting, we are able to do the scans through the NHS. So the patients doesn't need to pay any. You might get specific insurance companies or policies covering, but I'm not sure. We don't like use in that way. So again, it's only the FDG PET that we are doing in the NHS. We are not doing an amyloid PET scan, which is out of picture.
Okay, I think that's all. So thank you so much, Dr. Mithun. We've been getting requests from PGs to ask Dr. Mithun to take the session, but it is only now that it got manifested. So we're extremely grateful to you for having taken your time, from your busy schedule and finding time for us. It must be around 2 or 3, right?
Yeah, it's 3. It's close to 3. Yeah.
Yes. So thank